Hello there. So I want to start out by saying I've noticed from some of the questions that are being submitted that we have some dog lovers out there. There were dogs that came up in the questions on Slido, which I thought was very interesting. So let's look at some of the questions that you all asked. How do I access the file folder? I think someone was asking about training materials. So the training materials are available in the download section of the Home Health QRP training webpage, which I know you just went over that in your resource presentation. And following the training materials with the answers to the presentations will be posted on the HHQRP training webpage as well, so you'll want to check back for those. Are the rationale for the questions included in the handout? That's the same answer. Okay. Some question about weights. How do you handle weights on severely obese patients who weigh more than your facility scales read? Or in this case, your home scales read. If a patient cannot be weighed, for example, because of extreme pain, immobility, or risk of pathological fractures, the use of a DASH is appropriate. You can still document the rationale on the patient's medical record. What about patients that weigh over 440 pounds? In the unique situation that the patient's weight is greater than 440 pounds, a DASH should be used to enable the OASIS assessment to be submitted. There was a follow-up question about why are the restrictive parameters placed on the height and weight, i.e. height at less than 50 inches and greater than 80. And greater than 80, a DASH to be used per the 2019 quarterly Q&As. Okay. The data specifications were updated to promote data collection accuracy related to the use of the item for risk adjustment. Agencies are not restricted from documenting the actual height and weight in their clinical record. We had a question about the presenter emphasized the coordinated effort between the conditions of participation and the one clinician convention, implying that the resulting multidisciplinary approach is required. We thought the expanded collaboration was optional, which is correct. So the assessing clinician may elicit input from patient caregivers and other agency staff who have had direct contact with the patient to assist in completing any or all OASIS items integrated within the comprehensive assessment document. When collaboration is utilized, the assessing clinician is responsible for considering available input from these other sources and selecting the appropriate OASIS item response within the appropriate time frame and consistent with data collection guidance. If desired, though, agencies may continue to limit the OASIS to only that data directly assessed and collected by the single assessing clinician. Can you provide an example of when a DASH is a valid response regarding falls? Clinicians are expected to review the medical record and interview the patient and caregiver to obtain the information needed for accurate coding. Use of the DASH does have an impact on your reporting outcomes. A DASH should only be used when no information is available. There was a question, is there any way to prohibit the same fall being reported by two different clinicians, causing the fall report to count it as two falls? OASIS does not require any specific method for tracking patient falls. Use your agency policies and practices. Charlotte was our presenter, said that the 4 injuries listed are not an exhaustive list and use clinical judgment to classify falls. This is different from what is in the manual. Has this changed or did she misspeak? Major injury includes only bone fractures, joint dislocations, closed head injury with altered consciousness, or subdural hematomas. Some more falls questions. Code the fall no matter where it occurs, even if the fall occurred at the MD office. J1800 reflects falls that occur at any time during the quality episode, regardless of where the fall occurred. What about cases of suspected domestic abuse? where the patient claims a fall, but the bruises are inconsistent. So for this one, information about the falls should be gathered by the patient or caregiver report. Here's our dog question. If the dog in scenario 1 had jumped up and knocked the patient into the wall, it would not be a fall? J1800 should report any witnessed or unwitnessed fall or intercepted fall, except those resulting from an overwhelming external force or those resulting from intentional therapeutic intervention intended to challenge the patient's balance for balance recovery and training. So, if the patient has a dog that jumps on them and pushes them down, is this considered a fall for J1800? Does it matter if the overwhelming force is deliberate assault by another person or accidental from a pet? So the answer is the same. J1800 should report witnessed or unwitnessed falls or an intercepted fall, except those resulting from an overwhelming external force or those resulting from intentional therapeutic intervention intended to challenge the patient's balance. Am I understanding correctly that falls are no longer a potentially avoidable event? Application of the percent of patients, of residents experiencing one or more falls with major injury will be reported on the outcome report, not the potentially avoidable event report. What is the difference between scenario 7 and scenario 6? If you can remember back to those during the falls presentation. Scenario 6 is an example of an intercepted fall, and scenario 7 is a fall. Both are reported as falls on J1800. Somebody wanted to know the rationale for measuring patients' height. So the height is used to calculate the BMI, which relates to the risk for pressure ulcers. We had a question. It seems ground level falls are only being considered. Can clarification be given? A fall is defined as an unintentional change in position coming to rest on the ground, floor, or the next lower surface, such as a bed or chair. Somebody wanted to know, why was it important to remove M2250? OASIS item M2250 was used in the calculation on multiple process measures, which were removed from the Home Health Quality Initiative and the Home Health Quality Reporting Program in 2017. M2250 was then removed to assist in reducing the data collection burden to agencies. Slide 16, OASIS D. Someone's asking a question that they were hoping that we would be able to clarify comparing the M1800 OASIS function items with the GG items. Much confusion affecting this, affecting the consistent data collection. We are getting a lot of questions about this. So I will tell you that tomorrow, on March 6th, CMS will be posting a fact sheet called Understanding OASIS Function M and GG Item Coding. This document's intended to provide clarification that the intention is not for the codes on GG and M items to be duplicative or always match. Every OASIS item should be considered individually and coded based on guidance specific to that item. The fact sheet will be posted on the HHQRP training webpage, which you just reviewed. So that'll be good practice in going to that training webpage. And I think those are all our questions. There she is.